Well, I think that the development of more specific agents is a general theme that has emerged in targeted therapy. We realize that in many cases there's off-target toxicities. With ibrutinib, the principal off-target toxicity is the development of cardiac arrhythmias, principally atrial fibrillation in a number of patients. There's some off-target inhibition of the PDGF alpha receptor pathway, so there's some platelet inhibition, and so there can be bleeding events. And so a more targeted BTK inhibitor in principle might have some advantages. Acalabrutinib looks like it has a possibly more favorable side effect profile, but in the early studies that have been reported, it's not yet clear that it's superior in any way to ibrutinib, certainly in terms of efficacy. And so I think it will remain to be seen with additional studies where acalabrutinib or other second-generation BTK inhibitors are really going to fall into place in comparison to ibrutinib. And what I suspect is that, kind of like early use with tyrosine kinase inhibitors in CML, we'll probably start with ibrutinib, and if patients tolerate it and have a great response, they'll stay on ibrutinib. If they don't tolerate it, or if they have specific contraindications, perhaps an existing arrhythmia, that might be where we initially want to consider one of the second generation Bruton tyrosine kinase inhibitors such as acalabrutinib.